Welcome to today's ADEA webcast titled ADEA CCI Spotlight, Fresh Approaches to Assessment for Dental Educators. It's now my pleasure to introduce your host, Dr. Eugene Anderson, who is the Chief Policy Officer and Managing Vice President of the American Dental Education Association. Dr. Anderson, welcome to the program.
Thank you for the introduction, Kurt. For today's webinar, we're fortunate to have Drs. Catherine Demko, Jean O'Donnell, and Marnie Oakley with us to share their expertise on assessing students' ethical and professional behavior and evidence-based decision-making skills. Dr. Demko serves as Associate Professor in Community Dentistry at the Case Western Reserve School of Dental Medicine in Cleveland, Ohio. Dr. O'Donnell serves as the Associate Dean of Academic Affairs at the University of Pittsburgh School of Dental Medicine, along with her colleague, Dr. Marnie Oakley, who serves as the Associate Dean of Clinical Affairs. Thanks so much for your time and expertise in joining us today. For today's webinar, we have several learning objectives. Today's presentation and discussion will describe the Global Assessment Program developed and implemented at the University of Pittsburgh School of Dental Medicine. We will identify key factors for successfully implementing change in a pre-doctoral dental program. We will describe two assessment strategies for evidence-based decision skills in didactic and clinical courses. We will list 3 activities in faculty development for teaching and assessing evidence-based skills. And finally, we will identify lessons learned when implementing change and innovation into the dental curriculum. So Dr. Demko, welcome to ADEA's Leading Conversation webinar series. What can you tell us about the process and challenges that Case Western Reserve University faced while implementing evidence-based decision-making skills into didactic, preclinical, and clinical education?
Well, good afternoon, Dr. Anderson, and thanks so much for the invitation, and thanks to all of you who are joining today. I think most of us know that Standard 221 states that our graduates must be able to access, critically appraise, apply, and communicate scientific and lay literature as it relates to providing evidence-based patient care. The 3 boxes on this slide represent an organizational framework that we use to address the standards, mainly teaching fundamental knowledge and skills for evidence-based decision-making, providing opportunities whenever possible for students to observe faculty and preceptors practicing evidence-based decision-making, and finally requiring students to demonstrate the use of evidence-based decision-making in the clinic setting. The assessment strategies that I will focus on today are related to the first and the third boxes, while the second box mainly describes and deals with the faculty development to promote and model evidence-based practice. This slide really only needs the pictures, I think, to communicate some of what we experienced, and I suspect what some of you may have experienced when evidence-based practice began to be emphasized in the curriculum. Indeed, there are a host of challenges to integrating both the material and the assessment into the curriculum, but there are some enablers as well. The first 3 items on the left, the background, attitude, and content, while we found these were most closely related to learners and faculty anticipation that evidence-based practice was only about statistics, that it was only about the numbers, and there are rather grave apprehension about that topic. Frankly, I finally just had to use the example of a root canal and assure them that it's usually much worse than they anticipate. However, I will tell you that I'm not able to administer an anesthetic, so I suspect there was still some pain. But I'm happy to say that we have made great strides in making sure that everyone, all learners, understand that there's more to this than just the numbers, and that the scientific literature is only one part of evidence-based practice. And this second piece is really facilitated strongly by the faculty champions that we have who work with our preceptors. The next 3 items, format, engagement, and time, can certainly be process barriers, but they can also be transformed into enablers by recognizing opportunities that may exist in your curriculum. For example, in our curriculum, we have a hybrid format. That is, we have both problem-based learning and lecture. so that students were able to find adequate time in the PBL to be engaged in discussions around the journal articles and to demonstrate their growing proficiency in critical appraisal and to ask and answer questions of each other in their peer groups. I really can't emphasize enough the advantage of this small group format. And if you have small group opportunities in your curriculum, try to find ways to work those into your evidence-based courses. And if you don't, this is going to be an opportunity for you to be innovative in thinking about how you can create those opportunities. On the assessment side, I'm really just going to say very briefly that the clinical application requires the most effort to implement consistently and reliably in the clinic setting, and that the biggest challenges were really around faculty time for the assessment. And to address this, we've also begun to use group approaches within the clinic setting. Very briefly, we have a sequenced and progressive curriculum thread around evidence-based decision-making starting in year one. It begins with an emphasis on foundational knowledge for critical appraisal, and it's followed by some hybrid online in-person courses to supplement the initial topics and to build skills in searching and appraisal. This continues into the second semester of D1, and when possible, it's also incorporated into D2. And the challenge, as I'm sure most of you realize, is that the second-year curriculum is really quite crowded. During D3, there's a strong emphasis on the use of systematic reviews in the treatment planning course. And again, in D3 and continuing into D4, evidence-based practice activities are conducted in the clinical preceptor groups. And finally, in D4, there is an evidence-based competency exam is administered. I'm using very broad brushstrokes here just to show some of the topics that are covered in the 3-week D1 course, and I'm sure many of you include these same topics in your basic course. Most of the assessment format here is fairly traditional, homework, quizzes, multiple choice exams, but I do want to highlight the CASEL form that we introduce in D1 and use across the 4 years. CASEL stands for Critical Appraisal of the Health Science Literature. And honestly, it's just a name I made up about 8 years ago when I adopted the worksheet forms from the Center on Evidence-Based Medicine website at Oxford. The forms provide a structure to critically review an article. In D1, the students use them in group exercise, individually for formative feedback, and eventually then they submit a summative CASEL form for a grade. I will acknowledge 2 areas of concern with this form, and I think this is true for the CASEL as well as for any other forms that people use for this type of critical appraisal. They're very time-consuming to read and grade, and currently I'm the only one that does this in D1, but I am building some faculty capacity around that. And second, there's no guarantee of independent work. They do it, of course, not during class. But I have successfully circulated several true and several slightly exaggerated stories of how I detect shared work and the consequences of that. The other advantage to the CASEL form has been its role in faculty development. It has been a great tool in the introduction and application of critical appraisal for the faculty who have not yet received formal training in these methods. To continue with this, in the second semester of D1 and D2, we are refining some hybrid online in-person course modules that either introduce a new topic or continue to build skills in efficient searching. For example, I have piloted several rounds of a brief introduction to survival analysis in a module like this, a topic I couldn't cover in the first 3 weeks. So importantly, these new modules are designed to be integrated into an existing course so that the papers the students search and review are relevant to their current coursework. And of course, it really does require some close collaboration with the course director, which I have certainly enjoyed. In the D3 treatment planning course, the identification and use of systematic reviews is emphasized. This course is a strong example of modeling to the students the use of the best available evidence, in that the procedures, protocols, and materials that are presented in the course are accompanied by the best available evidence, integrated with clinical expertise and patient preference, or at least the hypothetical modifications, perhaps in a treatment decision that's gathered from the case-based scenario. For assessment, the AMSTAR tool is used to summarize the systematic reviews. The acronym stands for Assessment of Multiple Systematic Reviews, and I have put the reference there on the slide for you. Although it's 11-item format, so the AMSTAR is an 11-item format, and it uses binary yes-no responses, for our assessment piece, students must provide a justification for their yes or no answer. This tool is a nice complement to the CASEL form that we use, and as students become more advanced in their skills, it can be a more efficient form for critical appraisal and assessment. But you have to be confident that students know why they're answering yes or no. Finally, moving along in D3 and D4 in the clinic, these students work on evidence-based activities within their clinical preceptor groups. Once each month during regularly scheduled group meetings, students are presented with a clinical question regarding a treatment decision. They individually search the literature for the best available evidence. They decide on 3 papers within the group which 3 papers they would like to critically appraise, and then have a group discussion to apply that information to reach a decision. In this activity, emphasis is placed on efficient searching to find the articles and also on how this information would be explained to a patient. Of course, the preceptors are present in this course. It's within the preceptor groups. And in addition, several full-time faculty who led this implementation initially are also available to the groups. Currently, the assessment is formative, and it's included as a line item on the preceptor grading sheets. So the preceptors have been following and listening to the students all semester or for an 8-week period and are able to provide some feedback on those grading sheets. After several rounds of this, we're in the process of formalizing a summative assessment and are piloting some OSCEs around the searching efficiency task and some standardized patients around the patient explanation. Finally, in D4, there is a D4 clinic-based competency, and it currently exists as a line item on the competency exam for either a fixed or a removable prosthesis. This is a high-stakes item. If a student fails the evidence-based part, they fail the competency. Students complete the evidence-based process once as a formative exercise and receive feedback, and then the second time it is for the competency exam. The evidence-based packet was designed by our comprehensive care department and includes, among other items, a CASEL form and a patient information sheet where the student describes the clinical case and the PICO question for searching the literature. Completed forms must be returned 1 week prior to the competency. And at the competency exam, the student fields questions from the examiner regarding the evidence cited, and the final assessment is based on the forms and the oral responses. Now, clearly, for those of you who have been following the literature, this approach has many similarities to the triple jump exams that are cited in the literature. However, we don't do this as an overnight exercise, and we have a more limited number of examiners, so we believe that we have a bit more consistency in the assessment. And since it has been integrated into the existing competencies, it has not affected scheduling or a demand for additional examiners. The current full-time faculty that serve as competency examiners have been trained to conduct this evidence-based piece. I certainly do need to mention, of course, how important faculty development is to the success of this evidence-based thread across the curriculum. The most successful approaches have been faculty training that's centered around preparation for a specific task with the students. I have not been particularly successful in just giving general courses the way we do to the students to the faculty. Detailed problem-based learning manuals, certainly from my D1 course, have been used in faculty development, and that includes completed CASEL forms on selected papers. And this experience with those forms really does help faculty and preceptors build skills in questioning students about the literature they cite and being confident in their ability, their faculty's ability, to correctly judge the student's response to the questions. The goal, of course, for all of us is a critical mass of faculty, particularly in the clinic setting, that support and facilitate an evidence-based decision-making approach to patient care. Are we there yet? Well, not completely, but I think that the systematic approach that we've implemented across the curriculum has led to demonstrable gains in the skills and the application of evidence-based dentistry practice in our school. Finally, moving from didactic to clinical evidence-based practice and assessment. From my perspective, I'm not a dentist, so communicating early and often with my clinical colleagues has been instrumental in, I think, improving what I teach didactically and helping them and being support for them as it moves into the clinic. Support your preceptors is one of the most important lessons we've learned. Critical appraisal of the literature is a stumbling block in the beginning for our preceptors and for many of our faculty initially, and so supporting them, knowing that we're available to assist with their implementation in any of their classes is critical. Certainly we have linked our assessment to critical thinking. I think that the synthesis of all that information in treatment decision planning clearly supports a critical thinking process. I want to emphasize that the searching efficiently really does need repeated practice and assessment. If our students feel that they can't find the literature quickly and it's just too burdensome, they're never going to do it beyond what they do in the school. And obviously that's not our goal. We want them to do this. It's just a lifelong learning process. And I think the explicit definition and communication that this is a thread course has increased its sustainability, that students know immediately that they're going to see this topic over and over again, and I think it's sort of raised their efforts in acquiring these skills to be efficient and competent in these skills. I certainly want to acknowledge and thank my clinical colleagues, Jean Iandrea, Lisa Lang, and Soren Teich, all in comprehensive care, for their support and for their collaboration in helping move this from just the didactic course that I initially teach in the beginning throughout the entire curriculum. So thank you very much for your attention, and I'm happy to field any questions at the end at the proper time. Dr. Anderson?
Thank you, Catherine. We do have several of our participants asking how they can obtain a copy of the EB packet you mentioned and the CASEL.
So the CASEL form, I'm happy to share it. It really is adopted from the worksheets that are available on the website of the Center for Evidence-Based Medicine, but I'm happy to share those as well. I think for us the sustainability issue has been that I just gave it a name, and I would tell you that I could talk to at least half the faculty in the building, and if I said CASEL form, they would know what I was talking about. So that's actually been a very small but important step. As far as the EB packet, I actually would direct you to Dr. Lisa Lang, or I will speak with her about the availability of all the forms in that packet.
Okay, great. So we'll follow up with you all on behalf of the participants, and anything that we can make available to our audience today we'll do directly, so that everyone won't have to contact you individually, okay?
Very good. Thank you.
Great. And I want to encourage our participants, please send your questions in the chat box. We will have Q&A time at the end, but sometimes we take questions in the midst of the presentations as well. Now it'll be interesting to hear from our colleagues at the University of Pittsburgh on how they handle the implementation of change and innovation in their curriculum. But before we do, for any listeners who recently joined this webinar, welcome to today's ADEA Leading Conversations webinar entitled ADEA CCI Spotlights, Fresh Approaches to Assessment for Dental Educators. My name is Dr. Eugene Anderson. I'm the ADEA Chief Policy Officer and Managing Vice President. Our experts with us today are Drs. Catherine Demko from Case Western Reserve School of Dental Medicine and Drs. Jean O'Donnell and Marnie Oakley from the University of Pittsburgh School of Dental Medicine. Before we continue with our colleagues from the University of Pittsburgh, we do want to take 1 minute to get a sense of how many people are with us today. So I will turn it back over to Kurt, who will do a brief participation poll. Kurt?
Thank you very much, Dr. Anderson. You should see that poll opening on your window. Simply indicate the number of people that are attending at your site and submit that answer. Dr. Anderson, I see they're underway, so I think we can turn it right back to you.
All right.
70% should say shut.
All right. We will just give a few more seconds for everyone to put in their number. All right. And now I want to turn it over to Drs. O'Donnell and Oakley, who will be discussing the University of Pittsburgh's approach to assessing ethics and professionalism within the pre-doctoral curriculum.
Thanks, Eugene. Since we're talking about professionalism and ethics, we wanted to start with a poll to get an idea of how much this topic impacts other schools. So the questions, I believe, are up there, of how many cases of unprofessional or unethical behavior did your school respond to last year?
And all we need to do, the audience, simply needs to respond to the particular choice that best answers that question. We have options of none all the way through don't know. So if you can commit those responses, and we'll give everyone another 10 or so seconds to complete that, and we will then share those with the audience and look for some feedback from our presenters. And please conclude your responses. We'll end in another 5 seconds. And we have concluded the poll. The results are now shared with the audience, and I'll turn it back to Dr. Anderson and our presenters.
All right, thank you, Kurt. So it looks like we have our largest two groups. We've got about, I'm just trying to see the summary. Okay, great. So it looks like we have a large share of folks that don't know, and we have a small segment of our audience that said none, 23% 1 to 2 incidents, 15% 3 to 4, and 12% with 5 or more incidents. So I will turn it back over to Drs. O'Donnell and Oakley. Do you have any thoughts in seeing the responses to this question?
Yes, thanks, Eugene. I think it's indicative that this is not an isolated problem, that many of us or most of us are dealing with professional and ethical issues with our students to some extent. And I certainly think that don't know piece of 42% reflects actually a great number of cases that are probably out there. For confidentiality reasons, I know our school often keeps these things to protect the students, so many faculty would not necessarily be aware that we were responding to issues or that issues had occurred. So I'd like to talk a little bit about what is global assessment, just briefly, and then go into some of the reasons why we moved to that. So we implemented global assessment a little over a year ago, and it was a process to better assess the professional and ethical behaviors of our students. And we wanted to do this throughout all years of the program. So some of the reasons that we went this way were because of some of the processes we were currently using. For example, in grading, we were always assessing professionalism and ethics, of course, but the problem was that often these behaviors were just one part or point on a grade sheet, and that the point was sort of lost or diluted. The overall grade was diluted. And not only was the grade not reflective of these problem behaviors, but we felt that we weren't really giving it the importance that we believed it needed. And of course, it was difficult to remediate any behaviors that were not reflected somehow in a grade. Another concern we had was that a student might be struggling with ethical or professional behaviors in one area, such as comp care, and also in another area, and patterns of behavior may not have been recognized as early as we would have preferred. We didn't really have a central system in place that could communicate concerns about students across departments. Another thing that was an issue for us, we found out, was that we have policies in place for grading and promotion, for academic integrity and student conduct, as we all do. We didn't realize that these may not cover all instances until we were challenged legally. I'd like to tell you about a case briefly that, while extreme, will give you an idea of some of what any of us can face. This is a case of public record, so I'm not breaching any confidentiality issues. So we had a student who had a history of behavior problems related to professionalism, and culminated in a last chance warning from our student promotion committee at the beginning of his D4 year. Following that, he then signed an informed consent document for a patient in the electronic health record, and then lied repeatedly about it to our clinical dean, who happens to be Marnie, including actually making up an elaborate story about what time the patient came in, etc., until he finally admitted it was his signature, but said that he had the patient's permission. In any event, following that last chance warning, we did recommend him for dismissal. His lawyers had an emergency hearing, and the judge ordered us to bring the student back and let him finish his patient care requirements and competency exams, which he did not do, and yet we were still ordered to give him a diploma. The student received the diploma, he walked at graduation, and as you can imagine, our faculty were outraged, as were his peers. Although we appealed and we were supported in that, and we're now in the process of seeking to revoke his degree, it just points to the problem that, no matter how obvious those kind of behaviors would seem to all of us, it was still apparently what we had in place was not sufficient. So these things kind of all combined to create the perfect storm that led us to implement the global assessment process. And our goal was not to, catch anyone or out to get anyone. What we wanted was that all of our students would succeed as professional, ethical graduates of our program. We also wanted to have earlier identification so we could actually help these struggling students. And then lastly, we did want a process that should a student be unable to change his or her behavior, that we had a legally defendable process to move forward with. So Marnie is going to go into the global assessment details a little bit more of how it works and what it is in action.
Thanks, Jean. So where we started, it seemed really logical to us when we wanted to build our program to start looking at the CODA standards. And specifically Standard 223, as you see here, is talking about assessing overall competency and not necessarily looking at competency in individual competency segments throughout the curriculum. And that really spoke to us, especially since we really felt that these behaviors stretched across all disciplines. As Jean pointed out, that was the problem, because we were seeing all these behaviors diluted through each of these assessment forms throughout all of these assessments throughout all the disciplines. So this is what our clinical curriculum at the time, looks like and still looks like for the most part. We have our individual areas of disciplines, and maybe your school looks the same. And even though our global assessment was targeted to impact all 4 years of the curriculum, we really felt that it was in these clinical areas where we had the biggest challenge and things seemed the most broken. So it seemed logical that we start here. And what we were doing was hoping to, again, assess the student globally. And in doing that, what we did was we asked all of our clinical instructors and course directors in the individual disciplines to pull out all of their professionalism and ethical behaviors that related to a number of different categories, from patient management to critical thinking to infection control, and ask them to pull them all out of their individual assessment forms and give the data to us. So we were necessarily looking at all of the impact of those forms, but we wanted to let them know that we would be the ones to act on the sanctions. And they seemed very relieved by that. We had a number of retreats and mentioned to them, we still need you to assess these behaviors. It's very important that you look for all these things in the clinical environment or in any environment. Just know that once you give us the data, we'll take that off your hands and we'll respond to it. And that certainly seemed to give them a big sense of relief, because as you can imagine, responding to professionalism and ethical challenges and behaviors of students is something that is not very clear-cut. We know what we see. We know when we see something wrong. We don't necessarily know how to respond to it. So that's something that Jean and I took in our offices together. So here's what we developed. We felt it was important to have things pulled together into a course series, and we called this course series the Qualities of a General Dentist. We even had our faculty come together and define what we felt was a working definition of what a general dentist is and what they should be displaying. And this series of courses acted as a safety net underneath the general curriculum. Basically, every student is enrolled in a course each term throughout our curriculum. We asked the faculty member in all stages of the curriculum, whether it was classroom, preclinical, or clinical, to assess students' behavior at all times and input assessment data into a database. The database we use currently is Blackboard in our school, and we can talk a little bit about setup for that. But we set up two organizations, as you call it, in Blackboard. One was called a clinical organization and one a non-clinical organization related to global assessment. We also felt that we wanted to make challenging these courses and going through these courses very high stakes, so that if students struggled, certainly as Jean pointed out, one of our main objectives was to get feedback to students who really had a problem with understanding what the expectations were, give them an opportunity to improve, and move forward from there. But for those who failed to take heed to learning and really continued to struggle, we wanted to make sure that if you failed one of these courses, that indeed it was so high stakes that you would be dismissed from the school. And I know that sounds pretty drastic, but I'll get into how that happens in a few minutes and hopefully be able to explain exactly how that works. So looking at the courses together, like I mentioned, we had keep clicking, sorry. There we go. Oh, we seem to be missing a slide. Can you go back one? There it is. There you go. We had two sections of the course criteria. One was clinical and one was non-clinical. And what we tried to do was break out behaviors for students and for faculty in each area. Certainly, like an example of a clinical behavior might be a minor lapse in infection control technique, when a faculty member might witness and immediately correct that. Whereas in a non-clinical area, it might be something as simple as repeatedly arriving late to class or coming unprepared to the preclinical environment. So we also felt that along those lines, there were two levels of behavior as well. Again, using the infection control violation, if it was a minor infraction where the student may have inadvertently touched something that they shouldn't have or didn't have anything covered, that a faculty could immediately correct that and offer input. And that's at the level of a needs improvement, whereas an unsatisfactory behavior level might be something more significant, such as moving forward with a clinical procedure without faculty approval. We saw distinct differences between those and wanted to make sure that we outlined that to both faculty and students. And in doing that, we asked each department and area within our school we challenged them to try and think of some of the examples they would have in each of those categories, and we hoped that they would indeed then communicate those to the students. We recognize the fact that this is maybe a dangerous opportunity, and we did not want to get into a laundry list of every single thing that a student could do that wouldn't meet our expectations. So we really tried to limit those lists as much as we could, and then still end it with a phrase that we captured from our Office of General Counsel that sounded like "to include but not limited to" every time we use those lists. So in essence, let me show you just what this looks like when it's in action. So you may witness, or a faculty member may witness here at our school, a behavior that needs improvement. Let's say they're disruptive in lecture. You might see another behavior, or it might be the same behavior repeated. Let's say this new behavior, if it is new, it doesn't respond to an email request to meet with a faculty member. Perhaps another new behavior arrives unprepared to the clinic or the pre-clinic or class. Maybe the student is argumentative when receiving feedback from a faculty member. For us, once our students receive 4 needs improvement level entries, or 1 U needs improvement level, or 1 U behavior, we put our students on academic warning, and that's written in our promotion guidelines, and it's something that, we just meet with the students from the promotion committee and let them know that they are being put on notice. Jean and I then meet with the students and go over and introduce and implement a formal learning plan with them. Let's say they are in the process or working through their learning plan, and perhaps you see after that another behavior that needs improvement. Maybe they didn't get a consult in the patient care area before proceeding with patients. From then, stakes are a lot higher. We put them on what we call a performance improvement plan, kind of modeled off of what you would see in HR or employee relationships. It's kind of serves as one of those last chance warnings. And for us, it's written into our promotion guidelines that these students are placed on academic probation. So let's say that we move forward and still, oh my goodness, we still have behaviors that are not where we want them to be. Again, this could be anything new or old, and if this continues, ultimately it leads to a course failure. For us, these course failures come from Jean and I as the course directors. We alert the promotions committee, and the promotions committee would then dismiss the student. So because it is written into our promotion guidelines.
And just a few things to mention as well is we have not had this challenge yet in the court system, so that is, yet to happen. But one thing we have learned is there's still a lot of debate and uncertainty within the courts themselves about what constitutes academic versus disciplinary action, what we can do and what we can't, what we should be doing, what we shouldn't, especially in the areas of freedom of speech and social media. So, for example, with freedom of speech, we need to learn, we did learn that we can't confuse that with unprofessional behavior that is within an academic course or environment. And so, for example, we had a student actually present some slides rating our faculty using a thumbs up or thumbs down kind of thing to a group of other students. And we were not able to respond to that other than, talking to him and suggesting that might not be the best, most professional thing to do. But we weren't able to really put that into our global assessment database. And that was because anybody can say they don't like a course or don't like a faculty member or whatever. Another issue or consideration is social media. We had a student post a vulgar comment about another student. It was on a non-university, non-school monitored account. But the student who the comment was about showed it to me. And yet, unless it was persistent or offensive enough that it was considered bullying, we were not able to act since it was, again, not an academic-related offense. So those are just some things there's still much to be learned, and there's some articles out there that talk about case law and where they are with that. And in fact, here's some references about professional behavior, and one of them, really does speak to that difference between what a school can and can't, or should or shouldn't do.
Just in closing, I'd like to take just a minute to acknowledge two people. I don't know if Gary Guest is on the webinar, but he is the Assistant Dean for Patient Care at San Antonio. And many thanks to ADEA, especially BAFACA, for putting forth a forum so that people like us can have conversations to share material. It was Gary that originally talked about global assessment a few years ago, which made me ask him what he had at his school and if he would share it. And of course, in dental education, we're always willing to do that, and he was no different. So I really thank him for that. And here at our school, Rich Orovitz is our own Director of Instructional Technology, and Jean and I would be happy to elaborate a little bit on the setup in Blackboard and what it takes to do that if you're interested. But Rich was incredibly just skilled in Blackboard and really took that to task and made great strides for us. So we'd like to acknowledge him in that regard. So we'd be happy to answer any questions. Should this be the appropriate time, just let us know.
Thank you both. This certainly is a tremendous effort taking place at the University of Pittsburgh, and we really appreciate you providing us with some insight on this important topic. I want to ask all three of our experts today to share some insights of the lessons learned from implementing new assessments within the dental school's curriculum. Certainly, developing a new strategy and implementation have challenges, and I think for our audience out there, there's tremendous value in understanding the lessons learned after innovative places have gone through the process of shepherding new and innovative ideas into the curriculum. So can I ask Drs. Demko, O'Donnell, and Oakley talk a little bit about the lessons learned?
Yeah, so we really felt that most importantly, the timing really affected our success here. Like Jean pointed out, we had that very, very public, in a sense, legal case. And for us, our faculty were greatly in need of some support. And, you know, what we were forced to do with that student was indeed just that, what we were forced to do. And it didn't reflect what we felt was just. So they were in that situation where if we didn't implement something soon, they were sitting back, certainly in their chairs or in the clinic, thinking, you know, why bother? There's nothing I can do to positively affect change when we see behavior that doesn't meet expectations. So timing was huge for us.
Catherine, was this the case for you as well?
Yes, and I think for us, the opportunity came when we implemented the problem-based learning format, and that's been about 8-9 years now. That was just a great time to integrate the evidence-based practice. Certainly the beginning foundational knowledge became a course into of itself, and then I think opportunities began to present themselves as time went on, that this needed to go and be reinforced beyond what was happening just in a classroom, that it needed to be in the clinic. So the change in the curriculum was the first opportunity for us to make this change, and then I think you just have to keep an eye on the curriculum as the students are moving through and decide where else you could be bringing this in. And faculty champions, I would say that the emphasis by the ADA as well, some of our faculty have attended those courses, made a big difference.
Right. I think strength in numbers was really important to us. One of the things that Marnie identified early on was having a liaison in each department, and those people were ones that we worked with very closely, and then they in turn were there for their faculty in those areas, and it really helped to kind of spread the word and help people understand what the goals were and to participate in it, so they really did buy into the program.
Yes, strength in numbers and broad-based support actually came from the fact that in our PBL format, I have 7 other faculty that work with me in that D1 course. They are the facilitators in the small group situation. Most of them were also clinical faculty, and so that was the way that we began to garner strength within the clinical setting to bring this information into the clinic. And the broad-based support came from increasing the number of faculty who had that exposure, and definitely from our administration as well. They've been very supportive of all of these activities from the beginning.
Yes, and for us, broad-based support really stretched to all corners of our school, from administration to faculty. We needed a lot of IT support, like I mentioned, to set up these organizations. And, of course, we interacted every step of the way with our Office of General Counsel, who knew about our past issues, our current issues, as well as we met with students in a focus group. And oddly enough, when it comes to professional behavior, you may not realize, but if you get a group of students together, they really are looking at their peers, and sometimes they want their behavior to be just as good as we do. And it was in the students groups that we found that they were really getting irritated with those students who weren't pulling their weight and nothing was happening to them. So they were very much in favor of a program as well.
I think we also looked at things like follow-up and sustainability, where we communicate with students once the process was implemented. We communicated a lot prior to that with each class in person, and we continue to meet with them annually, and every term send out the information about the course as a reminder that they are again enrolled in that course. We had retreats. We sent surveys to faculty trying to figure out what other information they need or follow-up that they needed. We admit that we're not as good with sustainability as we would like. It's hard. As Marnie always says, we're better at thinking up ideas and getting them going than necessarily maintaining them because of the time frame that's involved. And we certainly do try to keep up with. We look at our outcomes all the time, how many entries have been made. We talk to faculty and, of course, the students. But making time is hard. I don't know if you have anything.
Yeah, one of the things I would say that helps us internally when we come up with an idea and we're putting a project forward is that implementing and developing as a team really helps, because then you can kind of check on each other. If I don't have time to do something, at least I can go to Jean, or vice versa, and between the two of us, we can check up and make sure that we're dotting all our I's and crossing all our T's, as it were. I don't know if you have anything to add to those two issues at the end there, Catherine.
Yeah, I would agree with the sustainability issue. The fact that we have sustained this and continued to advance it has been because we've distributed the responsibilities among more than just one faculty. And I think also this idea of the thread that the students themselves have come to realize this is going to occur more and more often, and that they're being evaluated on it, that there is assessment, has led to it being, I think, remaining within the curriculum. And I think also this idea of bouncing off each other, how it's working. I know that my course, which was strictly in the classroom, improved as I reached out to the clinical faculty for those opportunities, and certainly integrating it into other courses during D1 and D2 has made a big difference in this being sustained, and I think and also growing. So, yeah.
All right, well, we have time for some questions from our audience, so I will start selecting a few of the questions that we've received. One question, is anyone measuring the impact of EBD, the impact that EBD is having on patient or treatment plans?
So I would answer that we are not formally doing that. That's really a great question, and certainly a very challenging one to measure. We are not formally doing that. So in other words, I would be looking at it saying, have you, your initial treatment plan, is that where you would still be making that decision? Is that the same decision you would make once you had actually gone to the literature and tried to integrate the best available evidence? So I don't have any numbers on that, but I think that's an important question to be considering as we sustain this and perhaps move it ahead.
All right. Next question is, how does the students' use of media or not paying attention to lectures play into the idea of professionalism and global assessment?
That's a good question, and it's one of those difficult gray areas, I think, because it does in part depend on what the faculty member, the individual course director, has told the students. Certainly if they have said, everybody needs to have their computers off or whatever because we have a guest speaker, that happened in one course, and then people are not doing it. What we try to do is have faculty, if anybody can make a mistake or do something that's we don't like, but we try to get them to talk to the student first and just say, look, this is not really, acceptable. Why don't you just turn that off for that example? And then if it's when the behavior, happens again or the student doesn't respond, that would be an appropriate, I think, global assessment entry. Marnie, anything? Right,
and it's all based on a faculty member understanding that it's certainly within their purview to outline an expectation and expect that someone meets that expectation. And if they don't, as adults, you have a conversation and let them know, hey, you're not meeting this expectation. I want to let you know. If it continues, there's going to be an entry into the global assessment database. So it makes it easy for us. In essence, those are kind of a warning that the student gets, but I consider it more of an informational session with the faculty member and just communicating the expectation, making sure that they understand. But those are the exact kinds of things that go into global assessment. I can see from some of the comments in the polls, some people are asking about cheating and whatnot. So for us, those are in totally different, that's in our academic integrity guidelines, which is a totally different guideline and set of criteria and sanctions. So we always tell our faculty members, global assessment does not relate to cheating or the student code of conduct. That's another university-wide guideline that's outside of global assessment.
Yeah, there can be some overlap, but there are distinct policies on academic integrity, which basically is cheating.
Thanks for that clarification. And certainly there were several questions related to that. Next question In my experience, having remediated several students related to behavioral issues, mental health issues, and various learning disabilities seem to be at the root of these problems. How do you deal with these issues, and what support do you have?
Again, great question, and it speaks to one of our goals, which was to identify these students early and try to help them. And that really is, as much as this, can sound so just slamming them for things, we really do want to help them. And so when we meet with a student, or if it's a behavior that we don't always wait for the 4 behaviors to be entered. We can meet with the student and find out what's going on. But we also, our students know that our Office of Student Affairs is a place to go for assistance with that. And then we do have the university has an Office of Disability Resources, and we've worked very closely, Marnie, I, and our Associate Dean for Student Affairs, to help some of these students who are really struggling because of some of the issues that were raised, like some mental health and learning disability issues.
All right. So one final question. This question comes from me. This is a general question related to change and innovation in dental education. So with an already heavy workload as dental educators, what advice can you give our participants on how you find the time to work on developing and innovating in the curriculum, in addition to the already many responsibilities that many dental educators have?
Catherine, you want to start?
Okay. For me, actually coming up with some of the new ideas to implement is probably one of the most fun things we get to do. And I think when you first have those new ideas and you bounce them around, that's when a lot of the energy is there about, trying to implement something new. Probably the time where the real time comes in is in the true implementation, and then in the sustainability and continuing it. People do it once, maybe it worked and they are excited, or maybe it didn't work so well, and then that's where you really, I think, have to really make yourself find that time, set aside a certain amount of time each week to say, I'm really going to address this evidence-based issue in whatever setting it may be occurring. And I think, again, it really is some strength in numbers, making sure that you're not trying to do it alone. I actually did a lot of that early on, many, many years ago, and it's really been much more satisfying to find the time to reach out to other people to work on it. So, lunchtime is good, or, impromptu meetings, and I would tell you also that faculty retreats can be a great way, at least to make sure that other people realize that you want to talk about it, you're willing to be supportive, and to get that conversation going.
So Jean and I are nodding our heads the entire time Catherine is talking. We certainly agree. And one of the things that we felt really helped us is really, oftentimes we know we all have so many things on our plates, and, you struggle to get through the day sometimes, let alone the week. But, at some point you really do have to sit back with perhaps some quiet time and some reflection and think about how you should be prioritizing things. And for us, this topic, the stakes were so high for some of these issues that it just seemed so logical to us that whatever was on our plate, we kind of had to push aside for a little bit to get this rolling. Again, sustainability will be a task that we'll have to always look back to, but it just seems so important to us that we move forward with this. And we say this all the time. This is a lot of work, especially in global assessment. It's an awful lot of work to get this going for very little data, quite honestly. We're really, of all the students that we have 80 in a class of 4 classes. Currently having the system open for a little over a year, was a year in July, we have about 34 entries in our database across, I would say, about 15 or so students, and some of which, of course, have graduated. So it's very little data for a lot of work, but it's for good reason. So that's what we kind of look at and really challenge each other to understand that, indeed, across silos, that's where we have common goals.
Well, I want to thank all three of our presenters for providing wonderful information to all of our participants. Thank you, Drs. Demko, O'Donnell, and Oakley, for joining us. I also want to thank all of our participants for taking the time to be with us for this month's leading conversation. And I will turn it over to Kurt, who will give you final comments regarding evaluation and CE. I want to remind everyone that in the upcoming weeks, we will be sending information about our next webinar, so look forward to more details from ADEA. Thank you. Kurt, back over to you.
Thank you, Dr. Anderson. That does conclude today's presentation, ADEA CCI Spotlight, Fresh Approaches to Assessment for Dental Educators, brought to you by ADEA and presented by Catherine Demko, Doctors Catherine Demko, Gene O'Donnell, and Marnie Oakley. Your ADEA host was Dr. Eugene Anderson. We do hope you enjoyed the presentation. CE is available for this presentation. To obtain CE, enter your name in the site roster. You will receive an automated email with a link to the evaluation and a link to the certificate manager. Complete the evaluation form, and then you may retrieve your certificate. You'll be redirected to the site roster as we end the presentation for your convenience. Be sure to follow ADA Web on Twitter to join the conversation. Use the hashtag assessment. Again, that hashtag is assessment. You can find the recording and presentation of the program at www.adea.org/dental-ed-assessment, and that will be posted 1 week from today on November 2nd. Today's program is copyrighted in 2015 by the American Dental Education Association, all rights reserved.